Yeah. I mean, I do think that after a short while, the whole COVID situation went from being kind of a healthcare issue into kind of more of a political basketball game as well, with with
Mm.
casualties just happening, all around. Fairly early on, I think the data started to come out that there was, people from different ethnicities and non-white ethnicities were kind of becoming more susceptible to this. What was the reaction to that, and what was kind of some of the first steps that was taken?
Yeah, I mean, it was interesting at the time because, so first of all, it's important to kind of say the reason this wasn't obvious in day one is for two reasons. So one, on your death certificate, it doesn't record your ethnicity. So
Is there a particular reason for that? Because to me, that sounds a bit of a basic thing.
yeah, well, there's lots of things that you look at and go, wouldn't it be straightforward if we could get, all the NHS had one IT system and it all talked to each other really simply, so that when you change GPs, it doesn't take 16 weeks for your prescription instructions.
Yeah. No, I get your point.
There are loads of things like that. I think though in this one, I think bluntly, I think it's because no one ever thought it would matter. So the NHS, probably for about 30 years, has been trying to improve ethnic monitoring in patient data, so in particularly hospital data. And they threw money at it. They basically put bribes in. So if you were a hospital and you got 90% or above of your data was coded properly with people's ethnicity, you got an extra boost of money. Still didn't work, but it still really struggled to get that coverage. So, and then for death certificates, it was just never asked. So when we were in the early days, what we were hearing from communities was more people are dying from our community than from the white community. So we had a lot of anecdote, but not a lot of fact. And, we tried to work with funeral directors, but they were completely overwhelmed. They just couldn't fill in bits of paper. I mean, it wasn't they didn't want to, but, they just did not have any bandwidth to be able to do it. So in Birmingham, I mean, we brought together the Health and Wellbeing Board. We did an emergency session of the board, a public session in April to talk about the inequalities from what communities were telling us. And we live streamed it. We crashed the system. The council IT system couldn't cope. No one had ever listened in. I mean, at one point, we had over 400 people listening in live to a council meeting. Now, I don't think it's ever happened in the history of the council. No. So the IT just didn't cope. But even having recorded it was still downloaded. And we talked at that meeting about what is it we knew for fact, what did the numbers tell us? And two of our largest hospitals had audited their data. So they could talk about what was happening as inpatients, and that was showing some differences. What were communities telling us? And then, okay, so what do we need to do differently? There's still no evidence that says that people from different ethnic cultures, this disease behaves differently in them. So there isn't a kind of genetic difference as far as we can tell in terms of COVID. What there is evidence, very good evidence now, and it emerged over the summer, that your health before you catch COVID makes a big difference on how whether you survive COVID or not. So the biggest risk factor is how old you are. The older you are, the more likely you are to die if you catch COVID. If you're a man, you're more likely to die than if you're a woman. If you're obese or overweight, you're more likely to die. If you're a smoker, if you have a long-term condition like diabetes, high blood pressure, and if that condition is badly controlled, so your blood sugars, if you're diabetic, your blood sugars are all over the place. And then the final risk factor is if you're from a non-white British ethnic group. But what more and more we found as we've gone through the last year is the more you analyze the data, the more you go, well, actually the ethnicity difference is a result of the other factors, particularly the long-term conditions factor. And we've known for decades, and this is the sad thing is it's taken a pandemic for the rest of the world to understand what public health's been trying to get people to pay attention to.
Yeah.
If you are not white British, you are more likely to have some of these conditions because of lifestyle factors, deprivation. Some of it is genetic, things like type 2 diabetes in South Asian populations. There is a genetic component to that. But it's not just you more likely to have the disease, you're much less likely to get a decent level of care. So there was an audit, I think 4 or 5 years ago, of diabetes care nationally. And it really clearly shows people who are white got all 9 of the recommended boxes ticked. People who were from other ethnic communities did not. And it was a difference of kind of 40 to 50% in terms of the difference between different groups and the white British group. So as we came into the pandemic, these communities were facing additional challenges. The other things that we didn't talk about as much in the beginning, which we do now, is more people from our ethnic communities work in jobs that you couldn't do from home. So taxi driver, bus driver, care assistant, nurse, doctor, security guard. All of those jobs carried on working during the pandemic. Even in lockdown, they were still out doing their jobs. And therefore they were exposed. And they were exposed both because of the job they were doing, but also getting to and from work. Public transport, for example, particularly in London, was a very, very big transmission risk. And then the third element of this is also household composition, that the more people in your house, basically once COVID's in the house, unless you're really, really good and you've been using some of the things like germdefense.org to kind of look at your house and learn what you could do differently. Once it's in the house, it spreads through the house. So if there are 7 people in your house, 7 people get it. Whereas if you're only 2 people in your house, and there are many of our South Asian families, and actually many of our African and Caribbean families have kind of 2-3 generations living in the house together, sometimes 4. So they were also vulnerable because they had larger households, and once it was in, it just ripped through as well.